Good evening. Thank you for joining us. My name is Chris Rabbit with Edge Endo. Welcome you this Monday evening on the eve of Thanksgiving. Everyone's looking forward to a real nice holiday with family and friends. We're very fortunate this evening to have Dr. Charles Maupin with us from Lubbock, Texas. Charles probably needs a very limited introduction, but I'm going to give him one anyway. Charles grew up in Artesia, New Mexico. He graduated with a BS in biology from Lubbock Christian University and went on to receive his Doctor of Dental Surgery and degree at the Baylor College of Dentistry. Following graduation, Dr. Maupin attended UCLA, where he served as chief resident and received his endodontic specialty certification. He continues his connection to UCLA, serving as part-time faculty. Dr. Maupin is a diplomat of the American Board of Endodontics. He's an active member of the American Association of Endodontists, the American Dental Association, the Texas Dental Association, and the South Plains District Dental Society. He's also a founding member of the International Academy of Endodontics and is excited to be on the forefront in revolutionizing the field of endodontics, and specific to his contributions in the field of minimally invasive endodontics, and most notably and appropriately for tonight, field of advanced cleaning and disinfection in the space as well. So Dr. Maupin has done unarguably more cases in the YSGG, erbium chromium YSGG, laser-assisted endodontic space, likely than any endodontist, with thousands of procedures under his belt, has really, mastered incorporating the technology day in, day out on every procedure, and has really created an understanding around not only what it can do in the field of advanced cleaning and disinfection, but has really called out some of the other adjunctive benefits that really are helping to shape the future of minimally invasive endodontics and allow the specialty to really drive the category forward. So we're really excited to have him here this evening. The topic for tonight, as we all know, is maximizing efficiency and efficacy utilizing the EdgePRO and endodontic procedures. He's here tonight to talk to a little bit around how he's incorporating the device in specific case types. And then, of course, we'll share some cases. This is mainly meant for our existing user base. If there are folks on that don't have EdgePRO, welcome. But for those of you that have the technology and are incorporating it, hopefully tonight will help you even be able to incorporate the technology more deeply into your procedures. So with that in mind, we invite you to ask questions this evening. I will collate the questions and be able to ask them, present them to Charles towards the end of his presentation. So please ask away. This is your opportunity to get as much information as you intend to, so that you can continue to embrace the technology going forward. So thank you so much again for joining us. I'm going to now pass it over to Charles. Thank you so much, Charles.
Yeah, thanks, Chris, Zach, and the Edge team for having me on here. And like Chris said, this is kind of geared towards those that have the EdgePRO, that have used it. And so, with that being said, my goals for tonight is to really just focus on how to use it clinically. And we're going to do that by looking at a few cases, and I'll share some videos, and through that, ask any questions. And on this Monday night before Thanksgiving, don't want to take up a lot of your time, so we'll dive into this pretty quick and kind of forego any of the theorizing or postulating or diving into the in-depth analysis of it, and just kind of focus on the clinical use. Dentistry, it's a blending of the science and art. I've talked about this before with others that have been on, but the EdgePRO, it really helps us address the science side, which is reducing the microbial burden inside the canals. It helps facilitate tissue removal, thereby allowing us to facilitate, the white stripes, the art of endodontics, and the flow that, we go back to Schilder, and that kind of started the art of endodontics. And so it's incorporating the EdgePRO, the science behind it helps with that art of it. For those that haven't, you all know it's an open system. You're in control throughout the entire procedure. Works by fluid dynamics via cavitational streaming. Multi-cannular or unicannular, that's the benefit of the EdgePRO is, in the procedures that we're going to talk about, the way that I use it, we take advantage of each of these steps. We stay in the chamber for some, and we go down inside the canals where we maximize the fluid dynamics inside the canals. Use it at any stage during the treatment, and there's really no platform staging disruption to your clinical flow. It's pretty much, as you'll see in some of these videos that I show, I've got my handpiece here, I'm using it, and then I grab the EdgePRO, and it's just a toggle quick back and forth. And that's one of the things that I really like, is there is no disruption. It actually makes me faster clinically. So a few of my key guidelines when I'm using the EdgePRO, when you incorporate it, is incorporate the EdgePRO as early as possible into the procedure. We're going to dive into that, kind of what I mean by that as we go, the differences between a vital and a necrotic case. But the earlier that you incorporate it, the more disinfection you're going to get, kind of the easier your instrumentation becomes, tissue dissolution, just all those steps there. It aids with removal of organic debris early on, facilitates instrumentation, helps to minimize transportation of debris apically. And we know from all our lit, we're not going to dive into that tonight, but that's what causes post-op pain, pushing everything apically. That's one of the main indicators, not 100%, one of the main indicators that causes post-op flare-ups. So utilize the EdgePRO in between file usage. Now I'm at about 2 to 3 files per case is kind of maximum what I do. Finish most cases around a 20 for the kind of smaller canals. The larger canals are about a 30. So 17, 20 to 30 for most cases there. Guidelines, tip number 2 and number 3, those are to be utilized in the chamber only. I do not take those inside the canals. I think my personal opinions are have too much pressure, too much force inside the canals. So they are ideal for chamber use only. You can utilize them with solutions or water only. Tip number 1, this is to mid-root only. Again, this is from benchtop stuff that I've done. A lot of people want to take that, as endodontists, our inherent nature is to, hey, let me go a little further, let me push a little further. I strongly recommend mid-root only on that. That's how you avoid any post-op, any complications as you're in there, if you'll follow that procedure there. And you can, again, use this with solutions, water, the Triton irrigation. I know there's been some positives kind of with that Triton coming out, but bleach, EDTA, water, many of the solutions. Lower anterior teeth where you have a very small access, you want to adjust your watts on those. So from the typical that are set on there, I dropped those down to about 0.75 for teeth with small accesses. Too high up, then you're really, the fluid dynamics is really shooting the fluid out of the tooth, out of the access, and you'll see that in there. So it's really important when you're using this that you always have solutions inside the tooth. So we're going to dive into the vital protocol here first. This is kind of just if you want to take a screenshot of this, this is how I do it. And then we're going to watch a video. It's about 8 minutes long, and we'll go through each of this step by step. Access instrument to a 1704, kind of you want to remove that pulp tissue, good majority of it, before you introduce any solutions into the tooth. If you've ever treated a vital tooth and you put bleach in there, and if you're doing that constantly and then you're going in with files, I bet a lot of times you're packing a little collagen plug at the end and you're fighting to get patency on those. So if you'll avoid doing that first, go through this. A lot of times I just use water only, go in there, water, hand file, instrument to the 1704, and then we'll go in these steps here. Coronal conditioning, I use that with hypochlorite, the number 3 tip, chamber only, 1 watt, 50 hertz, air and water off. We do that. I have my assistant use 6 cc syringe. I'll go through 1 or 2 of those. I may mix in an EDTA in between, but usually 6 to 12 cc's of hypochlorite. Then we'll go to our instrumentation, and which is a 1720, possibly a 30. And in between those files, we're doing some canal disinfection using the number 1, 0.75 and 1.25 watts. These are all preset, and using solutions, fiber to mid-root only, and it's activated on the outstroke of it. And then as we go into here, we're activating on the outstroke, and then we're holding it once we get out of the orifice for about 10 to 20 seconds right at the top of the orifice, and we'll see some video of that later. And then we follow that when we're right before we're ready to operate. I do a final rinse with water only, 2 watts, 20 hertz. So let's dive into some video and let's see what this kind of looks like. So this is a number 31 and vital case. So just a little background, symptomatic, number 31. And we recorded this case here. These are the 2 files that I used on this case. I used a 1704. This is the X7 files. That's my preference of the file lines there, the X7 1704 and then the 2006. And so I'm just going to let this play and I'll kind of narrate as we go. And this is the number 3 tip, so it's already set on my EdgePRO. You can see off to the side there. So I've accessed the case and you can see it's vital case. We see some heme in there. So the first thing I'm doing is I'm taking my number 10 file, going into the canals, and I'm going to see if I get the red line reading on my apex locator. I'm in the distal canal on this one right here, and I can tell you that I did not get patency initially on this case right here with the file. So I worked a little bit. I don't spend a lot of time. If it drops, great. If it doesn't, that's okay too. You know, I write my link down 20 on that distal and we moved on. It wasn't patent though. When on the mesial canals here, we were able to obtain patency and confirm that with the apex locator pretty easily. I take all my stops off, as you see. I think it's easier to read the lines. So off the edge, we're at 20.5 off the buckle there, the mesial buckle. So we record that for, that's our mesial canals. I know based on the pre-op CT, my MB and my ML canals join there. So now we're going to come in, and I was 20 on the distal, so I'm going to instrument to about 19 with the X7. My assistant's just, you know, spraying off my flutes on my file. That way I can just continuously go in there. We don't do the peck wipe anymore. It takes too long. And then on the mesials, we were at 20.5. And again, we're going to go in there and cut some shape in there. And you can see we've got the lines going there. Rinsing it off. And I'll go, you know, if my hand file went pretty easily, then I'll maybe take this, but if it was tight, I'll stop it a little short here. If I feel like it's tight going in there. So we're at 19 there on the mesials. Then I'm going to come in here with the 20 and I'm going to open it up just a little more on the distal to 19. So we're on the distal canal here. We come in here again, opening it up. And then I'm just going to lightly bump the mesials just a touch, just to kind of open up that top part. Now we're coming in, we're starting the top step here. This is 1 watt, 50 hertz, the number 3 tip in the chamber only, the vital case. And so my assistant is going to syringe in sodium hypochlorite into the chamber while I activate. We'll go through a couple syringes here, you know, and it's all up to the doctor. You're in charge. If it's 6 cc and it looks like you're ready to move on, then go ahead. Or, you know, other times you say, hey, you know what, I went through 6, I still see some tissue kind of in the top part. I want to go through another round. We'll get another syringe out there and go through another round. So my assistant's in the scope with me. She's got a suction in one hand. We put an etch tip on the syringe there, the lure lock there. That way she cannot bind that down in the canals. She's lightly draping it over the access. She's keeping the fluids in there. I'm activating it, not touching the floor, not touching the walls, just activating the area. You don't really have to move it around. It's multi-cannular going on there, fluid dynamics going through that. You can see we've got nitrous on this patient as well. The little nose piece going on. Coming in with another syringe of it here. Now I'll tell you, I mentioned the nitrous. I always turn the nitrous oxygen down, way off, or even off when I use the laser. Other people I know continue to use it, but I tend to err on the side of caution for a lot of things. So I usually just bump it off real quick while I'm using it, and then I'll turn it right back on. Coming in, we're still in that top step with the number 3 tip. We went through that. I went through a few cc's or a few, you know, probably 12 to 18 cc's of that. And then our next up here, we're just gonna go, I've got one more here, looks like. So I went through 12 already, and we're coming to, decided I wanted one more. So we have 18 here that we're going through. And again, we went through this so you could see that, how she's managing it as well, to get another shot of that. So I wanted to show that camera angle of how my assistant handles that. And it just creates any spillover. You can see there's not a lot of splashing going on, minimal spillover going on as well. So you don't have to, ensconce the tooth with anything to prevent any leakage there. Okay, so we went with that. We're going to come back in here now, and I'm going to check my links again. And I put just a tiny little bend on the distal and popped right through. So removing that tissue made confirming patency a walk in the park. I mean, and I see that time and time again. I no longer spend a lot of time with hand files, working around, trying to confirm patency. If I don't get it, that's fine. Stop where you're at. Don't make matters worse. Transport, anything else, instrument short of that, go through your laser protocol, and then come back and repeat that step. So we got the X720 now. We're going to go in the distal canal. I'm going to take that to length. On the distal, the reference is the mesial part of the access. So I'm just watching the lines through the scope. Again, my assistant is spraying off the file as we go. And then since I have that on, I'm just going to go ahead and kind of bump the mesial canals as well. Facilitates instrumentation or obturation, makes it slightly easier. I've gone all the way from 1403. I finished cases like that, and I can do it. But what I found is when you bump it just a little bit with that 2006, it just makes the obturation easier. I don't think it's detrimental at all. I've gone, like I said, all the way, very small non-instrumentation as well. So we just completed the instrumentation there. So we got our honing file all the way on the mesial canals. Come in here, a little rinse, and now I'm going to show you a couple different ways that you can utilize. We're going to come in here with the number 1 tip, which is 200 microns on the inner. The outer diameter of it is 270 microns. There's our distal. You can see all the tissue in the coronal portion completely gone. We had all that when we first accessed it. Looks good. You can see the isthmus between the MB and ML was cleaned out. So now what we have on is like I said, the 200 micron. We're swapping that out. There's a 200 micron tip on the handpiece. It's somewhat flexible. So, if you go around curvatures, it'll pass easily the first time, but as you activate that, if you think of our old NITAP files, they have that tendency to straighten out. The same thing here. So that's why I stay, mid-root. I don't really go beyond curvatures with that. And what we're going to do here, if it's a tight space, minimal opening, a lot going on, you can fill the chamber with your irrigant of choice, hypochlorite, EDTA, Dawkins, Triton, whatever it be. Then we're going to drop that in. If I hit anything going in, I'm going to pull back a millimeter, and then I'm going to activate on my way out there. And so we don't have the sound going on, but we can see the fluid dynamics going on, activation going on. And again, it's important that we always keep a solutions fluid inside the canal. My assistant's going to hold the handpiece. I'm going to refill it. She's got the suction in there as well. We're swap back there. That's all done under the microscope. We're back in it, going through this protocol again. Again, it was popping out, so I want to refill. It's just a real quick change. And a good rule of thumb that we say is start this 3 per canal, hypochlorite, EDTA, and hypo, but blocked MB, MB2 canal, you're at 14 on that MB2. You'll want to spend more time on those canals. So as you use the edge, you're going to gain that just kind of situational awareness of, hey, you know what, this canal, I need to do a little more irrigation, a little more laser activation in this one versus the others. So here's another way you can see. Now my assistant's just going to constantly keep the chamber full. This way is quicker. Constantly keeping it full as I activate. I can go in and out of all 3 of the canals at a time as she keeps a constant fresh turnover of solutions going on there. So that's what I wanted to show with this video here. Then we're going down. She's got it refilled. She's coming back in. Or she picked up the other syringe. We have a couple syringes laid out on the side. That way she can just quickly reach over, grab another one, and bring it in. We're going to come in again here, do another round, drop it to mid-root, activate on your way out. You got the preset settings that are already preset on this for the number 1 tip into the EdgePRO, and where you can customize it as needed. You know, molars, I stick with the preset. Those lower end tiers, like I said, I drop it down to about 0.75. Now you can see I've got the number 3 tip back on, and you can go straight to water at this point in time for a final flush, or if you want to give it one more rinse with hypochlorite, that's perfectly good time to do that as well. And so that's what we did here. We came in one more rinse with hypochlorite, activated that. 1 watt 50 hertz when I do that. And now we're going to come into the last final rinse here with water, 2 watts, 20 hertz. And I do this anywhere from about 45 seconds to a minute. And we're just flushing all the solutions out so we don't push that out the end of the root when we're drying, when we're operating. Kind of cleans everything out there for that. The nice thing on the EdgePRO, it's got the little timer, as you can see there, counting up. So you don't have to sit there and count in your head. You don't have to guess how long you're going. You just take a quick peek over, glance at that. And you can see we're at 2 watts, 20 hertz, 90% water, 10% air. And that 2 watts, 20 hertz, that's 100 millijoules. So it's quite a bit. Never go inside the canals at that power. I mean, the Edge has as much power as you'll need for any procedure there. So, but 2 watts, 20 hertz chamber only. So we're at 45. I stopped this, like I said, about 45 seconds is where you want to run that. And so now you can see we're completely finished. You can see how clean the isthmus is between the MB and the ML. See down the canals, how clean they are. As users, you guys have already seen this. So I'm not showing you anything that's new here on that as far as just the cleanliness from a macroscopic, even microscopic level looking in here. You can see that. We can see our obturation. We got that little distal dilaceration. We got a couple accessory anatomy, distal accessory coming on, and then cone beam on the right. That's the mesial canals. You can see the loop. There was a accessory anatomy there, and again the single distal and lower right vital case. I typically see more anatomy on that. We see the little dilaceration of the distal. We maintain the canals. Left a little depth check there on the distal, if, just in case entry was ever needed. Don't like it when I leave those little voids there. But, I wanted to show that video. I think it really shows the vital tooth protocol that we follow. They're very similar. The only difference between the vital and necrotic is the vital, I want to get a 1704 tooth length, or, within a millimeter or 2 of working length, kind of remove some of that tissue. That way I can get going with the irrigation on that. This patient here presented, she came in for a consult early in the morning and was in a lot of pain. And so I rescheduled her for the end of the day for treatment. And what I like is, if you have, it's not just a matter of having the EdgePRO. It's if you have the systems in place and the right technology, these two working in tandem, you can work in another patient, that patient in pain. And what I like, this case took 45 minutes at the end of the day. Did it not too long ago, a couple months ago. But what I like about it is these are some of my favorite case types to treat. Patients in pain, they want to be in your office, and after you go through this, I mean, their pain is significantly reduced, if not gone, the next day when you go through this procedure utilizing the EdgePRO there. So again, some of my favorite cases to work in. They're so thankful when you go through these. So again, the step process on this access was a necrotic, or it was going necrotic. So it's kind of you open in there, basically necrotic till you get the very end, and there's a little vital tissue there. But opened into it, ran through the water. We went 2 watts 20 hertz water first, some instrumentation, went through the number 1 tip there, and we're about to jump into that, and then we obturated the case there. So the necrotic protocol varies just a little bit, and that as soon as we access the tooth, before we introduce any instruments, and again, when we talk about what causes a lot of the post-op flare-ups is pushing debris apically. So before we instrument it all, we're going to run 2 watts 20 hertz the number 3 tip in the chamber only, 90% water. You can have the air on 5% or you can turn it off. That's what I do. I just run it with water. It's easy. If you want to get started with hypochlorite, that's perfectly a great time to do it as well. So you can have your assistant syringe that in, go 1 watt, 50 hertz on that, air and water off if you were to do that. So you can go the vital coronal conditioning step, or you just grab it with the water, do that for a minute, cleans everything out, allows you to see the canals, identify them. Then we're going to drop down 10 file in, see if we can confirm length. If we can, great, game over basically. Then we go small canals, 1704 to 2006 is what I'm doing. Medium large, 20 to a 3006. We're going through the canal disinfection in between each file usage, and then again at the end. Again, 0.75 to 1.25 watts, 50 hertz, air and water off, mid-root. Assistant's gonna fill it. Narrow anterior teeth. With the narrow anterior teeth, I do not do continuous flow. There's not enough room. I don't want that tip binding in there. Again, I always err on the side of caution. And then a final rinse. So let's take a look at a couple videos of what a necrotic looks like. Well, here's the first case. This was on a referring dentist, a good friend. It was on his dad. Came in and I placed that implant on him as well. Number 3, done quite a bit on him over the years. But number 2, you can see just on the image on the left, we see a big palatal canal, something distal, not much visible on the mesiobuccal root over here, right here. So we went through and I was able to find the palatal DB and the MB2, but trough, dug a little bit, could not find an MB1 canal. Went through the laser protocol that we just shared, and on obturation, I noticed some sealer kind of coming up there, and so it retrofilled the MB1 just from our fluid dynamics imparted from the laser on that case there, and hope to have a recall on this. But you can see the pre-op CT, axial slice on the left, palatal, DB, MB2, and there was just nothing to find up in here, and I didn't want to go in no man's land on that. And so again, another necrotic case. We went through here, did a little, this one just needed a very minor gingivectomy. So little minor gingivectomy with the EdgePRO. Access, went through the instrumentation, protocol that we just went through that I showed you the necrotic. You can see the webbing going on between the MB and ML canals, and even the minor gingivectomy just makes restorative a walk in the park there. So let's take a look here at what this looks like on a video standpoint. Carious premolar isolation image on the left. This is before anything's done. Image here on the right is following caries removal, and that's it. You can see kind of the liquefactive necrosis going on there in the buccal and palatal canals. And so what we do, we started here, we cleaned everything up, we just dry it off. You don't have to etch or bond or anything. And then we're gonna flow some cool dam around here just to create a little little platform, little barrier there, so we can come in here and use the fluid dynamics from the laser. So just a little cool dam through there. And here's our video. And what I want you to see here, we're coming in here. This is water only. I'm gonna slow it down, and you're gonna see a huge chunk of tissue, even on, if you can saw it, come flying out of there. And that's why, imagine had we not done that, we're pushing that stuff open. So look right up here, saw a huge chunk of tissue. Right here. Now on this one, I have just the number 1 tip on. Smaller tooth, so I don't need to go to the number 3 on here. We're gonna have the number 1 on for everything on this one. I still have it at 2 watts, 20 hertz. I'm not going down inside the canals yet on that. We're just staying in the top part of that. We don't want to go in the canals, like I said earlier, with that 100 millijoules. So image on the left was after caries removal, nothing else. Okay, image on the right, isolation, and just running the laser. You can see how much cleaner it already is. It's already opening up that isthmus between the buccal and palatal canals as well. Okay, so we've done a little instrumentation. Coming in now with the number one tip, we're going to go to mid-root. Nothing sound on this one so you can hear it. And first, I wanted to come in with just a little water. That's the product cases. I think you can use water. You know, to do a lot of it. We still need to use a little bit of hypochlorite until we have further, you know, evidence that shows water is just as good. But in the meantime, still use some disinfectant with hypo, Dawson solution, tighten something for that effect there. So I'm kind of just going back and forth between the two. And now what we're going to do is we're going to come in with our solution. So hypochlorite. So I changed my settings now on the EdgePRO. Now I'm syringing it on this case here. Again, too small, no room for error here. I don't want her doing continuous slower syringing again. Even though she's optimized. Dropping the fiber now. And you can see the activation coming up the other canal. So I know this is two canals. They merge. So now I'm holding it. So this video is great to show. I go to depth, and then I'm holding it for about 10 to 20 seconds. I drop it down, and slowly pull it out, suction. And you just hold it right after you work it. 10 to 20 seconds. You're going to replenish the solutions here. Looking great, okay? Go back in, activating, slow withdrawal, and hold after you work this level. Now you can see it's shooting solutions. You'll see this, you know, as usual, you've already seen this. I mean, it shoots the solutions out of the tube. So it's coming out, especially when you put it out. It goes down one and it comes up the other. Splattering up on my mirror a little bit as we go. Go back in. And just hold. One more time. We're going third round here with hypochlorite. And once you get in the flow on these cases, I mean, these cases all in. After anesthesia, I let it sit in for a good 15 minutes. I really like to let it sit. I mean, you're 40 minutes. Once the hand piece touches the tooth, with the laser, that max with the buildup and everything. So, systems in place. For sure. So final rinser with water, back to 2 watts, 20 hertz. I left the number one tip on for this. Again, we use the number one tip only. Molars is when I really alternate between the 1 and 3. I personally don't ever order the 2. Only tips I have are the number 1, 17 millimeters, and the number 3, 10 millimeters. So those are the 2 tips I have. It's easier to keep track of inventory I found when I don't have 17, 21, 25, 1, 2, and then 3. So 2 tips, all I need. All right, so we dry it and we operate the case.
All right.
So microsuction, so they drain together. So image on the right here, this was before any instrumentation, just water only. And you can see it's very clean. You can see the isthmus here. Now this is after a little instrumentation running the hypo and EDTA. Look how much cleaner the isthmus is. Kind of remove some of that calcification between there, cleaned it out. So you can just see how clean everything is looking in there. Pre-op, post-op, some lateral canals filled there, a couple of fiber posts, case restored. We did a little gingivectomy on this one as well to aid with restorative going on there. Kind of ancillary uses here. I treated this case a couple years ago, and the laser really helped in me being able to identify that split. Initially, I couldn't see it. Once I got everything clean, I was able to fill it and split it. He came back a couple years just having pain, and it was a cracked tooth, so I was a little suspicious. It's like, oh, maybe that crack, progressed. Sometimes in spite of everything we do, the cracked teeth, still head south. But we took the CT, and what we saw was this little bony exostosis that he has here, a little fenestration of bone going on there. So we kind of worked that out there a little bit using the laser. Went in, if you see that, a lot of times you'll have these cases, patient will be referred for endo, you take a x-ray, everything looks perfectly fine. You look in their mouth on the lingual, you'll see it. So you remove that little bone, and what we did, we came in here, used the number 3 tip, kind of opened it up, cleaned the area out, and it helped me fish out that piece of bone there. And I mean, it's almost instant relief. It's like a huge splinter. The patient feels instant relief. So just a little ancillary use. Also use it in sinus tracts, endoperio components as well. Necrotic protocol here. Fairly recent case we went through, exactly like we talked about earlier, just show a case, cleaned up, small little gingivectomy there, but you can see the multiple, little anastomoses between the canals, the distal and the mesials going on, several POEs going on there as well. Just kind of want to show this. This is just, again, you guys have seen this. Since we get in there, just to keep everything moving along at a great pace. I've got that filled with docking solution on the back wall for my assistant, and so she's spraying the file off with that. That's why I put this in there again. Again, we've seen that on several cases. Now we're coming in here with our solutions. And we're getting close here to kind of wrapping it up, but I want to show a little interesting thing on this one here. I noticed it on the pre-op CT. This piece had a little vital tissue in it. Open real big. So we're coming in, and notice on this canal when we first come in here, you'll see quite a bit of heme kind of come out of it on that one there. Taste is good, not throwing anything. We're going to come back in again, rinse it out. So much cleaner, everything's already looking one round. Now notice when we go back in that same canal, activate, perfect. No heme, no nothing. There's a resorptive defect in there, so it had some resorptive tissue going on. That it just facilitated removal of that. Now I'm holding it for about 10 seconds, just making sure we really activate that right in that defect. And again, I noticed it on the pre-op CT when I was going through it. Activate the hole, going in the distal canals now. Again, the mid-root. Activate the fiber on the way out, hold for 10 seconds. Funnel conditioning step, this is just water only, no air. Sometimes my system will blow my mirror off just so you can see it, but it's kind of blowing all the water out, so I have to not blow any air on there. And so for this one, I just left the number 1 tip on it, so switching back to the number 3, and that's perfectly fine to do. I like starting with the 3 because the higher power, I think it kind of degrades that pitch a little bit on the smaller ones, and I want that tip to be pristine when we're down inside the canals for the original work there. So you can see minimal instrumentation. These were 1704s with a little overlap of a little 20 just for obturation. You can see right up here, this is where the resorptive defect kind of ballooned out there. We got a little mid-root portal of exit, couple down here as well going on. So pretty straightforward case here, but you can see that coming off mid-root right here on the axial CT right there, slice there as well. Now, I want to briefly touch on, and this is going to lead into, you know, hopefully Chris and then will invite me back to talk a little more because I'm pretty excited about this. And the EdgePRO is the workhorse. You know, I think every endodontist should have it after using it for 5 years. And I mean, like I said, it's got plenty of power for everything that you need to do. You know, I think we're often heard is power, power, power. When I first started, is kind of what I thought. But I've added in a diode laser. I think there's several good ones out there that you should look at. But the diode laser in combination with the EdgePRO. So the EdgePRO does all the cleaning, disinfection, gingivectomies in the anterior, but for posterior, which is where a lot of our bread and butter is, the diode gingivectomy to me is just taking everything to the next level there. So the EdgePRO imparts the fluid dynamics, cavitational streaming, leading to faster tissue dissolution and canal cleaning and disinfection, decontamination of endoperioral pockets and sinus tracts, and it's got the gingivectomy functionality as well. The diode, posterior gingivectomies, and is bone dry when you use that. Now it works by a different way than the YSGG, but very effective. And there's a potential for some secondary canal disinfection after you go through with the EdgePRO. You cannot use it before, so not going to work for any of that. You've got to use it afterwards, but that's kind of being investigated kind of in earliest phases. And I'll tell you, Edge is very receptive when I'm kind of bringing some of this stuff up to, they're wanting to take endo to the next level and do everything we can to maintain minimal invasive and maximum canal cleanliness. So I just want to show a few cases here. I'm not going to show any videos of this right now, but hopefully, like I said, they'll give me an invite back to kind of share a little more on this as we go. Tooth number 19, pretty calcified case here. You can see deep decay. I've got a practice limited, I place implants as well, and I've got several buddies that we've taken courses over the years as well, and I think we're seeing the pendulum, on top with them swing back towards saving teeth. And I can tell you, teeth are more forgiving than implants. If you follow your implants over time, you're going to start seeing some issues with these. And so, at one point in time, this may have been a tooth that say, hey, let's take it out. Not anymore. With, again, right systems in place and technology. I mean, for me now, my standard MO is the EdgePRO and the diode for this case type. And these are all in a single visit to about an hour of treatment. You can see just how clean the restorative is. We've seen this back to the RD not restored. I think it's going to be tough, and that's where the case can be made by implantologists for implants. You restore a case like this, very clean margins, they can do margin elevation on this with the crown. The important part is the contact and the contours of the crown. That's what's important. I don't care if the crown margin's up here, but if they have a nice contact and contours of that. Upper premolar, I've got a few pictures on this. This was right after caries removal. Bloody mess in there. Clean everything out. This was diode gingivectomy. Absolutely no bleeding. I don't have to scrub this with Viscoscat. I don't have to come back later. I don't have to do pre-endo buildups. I know a lot of people do pre-endo buildups. That takes time. I want a one-piece core at the end. I don't want to, take a step backward and then move forward there. So just a little cool down. Go through the protocol like we talked about earlier. Matrix band there. Obturate, restore, lateral canal, case restored. Nice margins, a couple metal posts in there. I've gone more towards metal posts now. And we can get into that. Again, you can see that the tissue is way up here, decay's way down here. Come in here, gingivectomy, it creates a nice little trough for restorative earlier. Went through the protocol that we talked about earlier with the laser. The EdgePRO cleaned it all out. Look at the nice contour that we have on that and the nice margins that we have. Again, this is what it looked like. Before anything, decay removal came in here. And this is why earlier I prefaced this, I said posterior. I don't want to leave someone with these charred, anterior gingivectomies. So I'll use the EdgePRO for anterior teeth, but posterior, this is my preference here now. creates a nice little trough there. Matrix slides right down there. No bleeding. I've already gone through all my cleaning disinfection. There was no bleeding, no contamination in there. I popped that little cool dam off. I slide my matrix on. Again, there's still no bleeding. There's the matrix. I just tacked it with a little cool dam, BioClear matrix, trim it up. And again, nice contours there. This is a 2-year recall. I just want to show a couple of recalls and then we'll wrap it up and open it up to questions. I treated tooth number 2 and 3. I saw this patient back. This was a 2-year recall. Said saw her back for a treatment of tooth on the other side, so we snagged them. But you can see maxillary sinusitis going on. Communication number 2, pretty large. Great healing going on here. Tooth number 2 in the top. Tooth number 3. We also ran the number 3 tip down that pocket and did pocket decontamination with that. Great healing going on. 4-month-old, 84-year-old. Just got this recall in recently. You can see maxillary sinusitis going on here. A large apical finding. This is 4 months. Nice healing going on. CT, pre-op, MB root. You can see that MB2 dove back in. Sinus nice and clear, completely healed, almost completely healed there as well. 18-year-old. So I had age on my side here. Last recall, and then we'll wrap it up for today. Tooth number 2. This is a 2-month recall. So I started back for another tooth, snagged a recall here. This is pre-op, immediate post-op. Completely blown out. I mean, this tooth was mobile. 18 years old, told him it was worth a shot. Parents wanted to keep it. So went through our decontamination. We also dropped the fiber down pockets and in the sinus tract. She had a sinus tract on this one. Did decontamination in the sinus tract using water. That's at, you're going to run that at 1.5 watts and 30 hertz. And then your water is going to be about 50% air, about 20. And again, palatal root, look at the nice osseous regeneration going on. I mean, 2 months, almost complete healing. Pretty fantastic. So with that, Chris, I'm going to turn it back over to you. Wish everyone a happy Thanksgiving and hope you enjoy the time spending it with your families.
Well, great. Thanks, Charles, for just another really impressive tutorial. It was excellent. Really, I say to the audience, what we're trying to do here is continue to build this body of training and professional education such that we know the beauty of this technology is to continue to allow you to perform endodontics the way you're accustomed to doing it. But then how do you incorporate a technology like EdgePRO into your work stream? And I know many of you are doing it, hence that's why you're on this webinar and looking for more tips and tricks and pearls to be able to master this more effectively. So we're going to continue with these learning series, if you will. Dr. Maupin has been gracious with his time and his expertise and is always willing to share his tips and tricks. And, he's always on the forefront of coming up with the next pearl, the next, just little technique nuance that helps you, really kind of either get through a learning curve or really kind of just begin to capitalize on the value that you're seeing with a technology like this. So I do have a couple questions for you, Charles, if you don't mind.
Yeah.
Let me see if I characterize this first one right. You mentioned tip 2 being too powerful. If 1.2, this we may be splitting hairs here, but if 1.25 watts on tip 1 is approximately adjusted to 0.7 watts, how is that notably different than setting tip 2 to 0.7 watts adjusted down to 7.7 watts?
Well, there's also a calibration coefficient on these tips, which I did not go into. And the number 1 tip, it's about a 50% calibration coefficient kind of reduction on that from the power that's there. The number 3 is almost a 1-to-1, and the number 2, kind of from memory, I'm thinking it was around 90% or so. Chris can maybe help me out on that if he remembers. 80 to 90%, I believe. So there's that also built into it. And when you go through that, I think your rep could probably help get that for you, but that's something to take into account. But I also think that just the overall diameter of that number 2 tip is a little too big as well.
Great. Yeah, we can review those calibration coefficients. As you mentioned, they are slightly different, but that is the reason for that differentiation. Can you elaborate on keeping mid-root even with water?
As far as you know, I don't know, maybe is there any more to that question?
No, I
Not
think
really.
maybe as far as, from a pure kind of high level technique standpoint, maybe that's what they're getting at.
Okay. I mean, my preference for any of it is mid-root. The bench top that I've done, just spending time in there, what I see is that mid-root is efficient to clean to the end. Some people with water only want to go to the very end -1. That's fine too. I think that's with water only completely safe. But just turn the water on to 90%, air 5 to 10%, mid-root, activate on your way out. Same as you would with solutions. Nothing changes, regarding whether you use water or solutions. So.
Okay. Any tips on reducing ledging?
Again, the ledging, always activate on your way out. That's another reason I don't like the number 2 tip in there as well, but activate on your way out. Understand the power that's going on. It's always moving. Stay above a curve, mid-root only. If you do any of that, if you follow all that, now I will tell you early on, you will get a tactile feel to it as you do a few cases. If you put the fiber in, foot off the gas, you put the fiber in and you feel it, touch the canal wall, pull it back just 1 millimeter and then activate and go, and you'll avoid it. I mean, I can't tell you the last time now that I've had it. Now, you got an MB2 that takes a sharp, abrupt curve, as it can right off the floor. Don't put the fiber in on that one, okay? Just stay right above the orifice, activate it right there. But again, you'll gain this tactile feel. I mean, I can actually go in and out now with my foot on the rheostat, without even letting off, because I have the feel of it now and not an issue. But until you get that, activate on your way out and again, stay above the curve.
Great. You talked a little bit about gingivectomy. Can you speak to the technique for gingivectomy?
Yeah, so the gingivectomy with the EdgePRO, you're going to use the number 3 tip. You're going to go 2 watts, 20 hertz, and you're going to kind of have, so the number 3 tip, it's a 15% firing apically and 85% lateral firing. And so you're going to kind of rotate it just slightly, and it's not a fast movement back and forth like you think. You're going to hold it about 0.5 millimeters away from the tissue. So the way that it works is, the primary chromophore that this works on is water, and it's water and hydroxyapatite, but water for tissue. And so it's seeking that water out in the tissue and ablating it. And so you're going to be, half a millimeter to a millimeter away from the tissue, and it's a real slow movement along the tissue to kind of ablate it and remove that tissue. Whereas the diode that I briefly touched on, and I know Edge is excited about that part as well, and kind of looking to that works by heat, and that's direct contact. But you also saw the negative to that is you saw a little bit of charring of the tissue. So there's a balance between the two and a trade-off, kind of depending on where you're at. But anteriors, I'm going the EdgePRO there, but that 2 watts, 20 hertz. You may have a little bleeding with that one. A quick scrub with a little Viscostat, Cutrol, something like that takes care of that.
Excellent. And looking at the program protocols, can you sum up when I might want to use the system dry?
The only time, there's always a caveat. The only time that I use it dry is a immature open apex tooth, and I've got some cases I've showed before with that. Lights giving a glare. Immature open apex tooth, 8-9 trauma teeth. Young patient comes in, and there is some research behind using it dry, but that's when I don't use solutions. I don't want to activate on that, so I'll use water first, and then I dry it out, and then I'm circumferentially moving that fiber around, contacting the canal walls, because this does penetrate into the dentin up to, depending on what you look at, can go up to about 1 millimeter penetration into the dentin for that deep dentin disinfection. So that's the only time that I use it dry.
Excellent. Very helpful. Not sure this is a question, maybe a little bit more of a statement, but maybe enlist a little commentary from you. It seems tip 2 is most versatile with potential use in the chamber and in the canal mid-route for conventional non-MIE preps. I know you mentioned that you don't really take tip 2 down into the canal, but for larger prep canals, would you feel okay with that?
So I don't have really much experience with tip 2.
Okay.
So I would personally want to do some bench top work. I would, trying it out. I may, water only with that tip 2. I'd want to know, I've done a lot with the one, so I know. I mean, I've been using it for 5 years.
Yeah.
I've had 0 incidences. With the tip 2, again, I said that calibration coefficient is different. I'd start down with my power a little lower, and then maybe go up. But again, from everything I've done, the 5 years I've been using it, thousands of cases, my partner using it, thousands of cases as well. I don't see a need. The number 1 does everything we need to do.
Right.
The 2 is great in the chamber, and the 3 is great in the chamber. So the advantage of the 2 in the chamber is you can get a 17 millimeter length, and so it gives you a little more, wiggle room, a little more height, kind of moves the handpiece back a little bit so you can see a little more.
Right.
And that's the advantage of that one. But again, I don't have experience with the 2 in there, so I'm not going to speak on that. But the 1 does everything I need.
Fair enough. Well, I think that's it for the questions we had, unless there are any other last minute questions here. We'll certainly have more time with Charles. As I said, we look to do more of these as the body of experience continues to build with EdgePRO, which is exciting to see, close to 600 endodontists users now and growing. As Charles mentioned, Edge is certainly very committed to this category. We are looking at some additional technologies, including the 980 wavelength diode as a potential for kind of dual wavelength exploration opportunity. It wouldn't be necessarily that you're out buying more lasers. I think that there is an opportunity potentially to incorporate dual wavelength into what we're doing. We've actually, the real estate inside the EdgePRO system allows for that. We built for that and designed for that with our partner BioLace. There are also some very economical standalone diodes also made by BioLace, their Epic laser line, and some others that we're looking at. So as Charles mentioned, the workhorse is EdgePRO. You gotta achieve the initial cleaning and disinfection with EdgePRO, and then coming back in, there's some very exciting research being done on disinfection with a diode, following the initial cleaning with YSGG. And so we are looking at that. I'm sure many of you have access to some of the papers that are being published on that. And so that's kind of version 1.5, 2.0 as we're going down this road and kind of creating a product roadmap going forward. But certainly you've made the right choice moving forward with YSGG, and we'll just continue to provide as much education and experiential knowledge out there to keep everybody apprised of the latest and greatest. And so again, we really do appreciate, Charles, you spending time with us. Always very informative. And with that, I think we'll ride at 6 o'clock Pacific time, 7 o'clock Mountain, 8 o'clock Central, 9 o'clock on the East. You guys, everybody wants to probably go watch the Chiefs and the Eagles play. So anyway, have a wonderful evening. Thanks for joining us, and I hope everybody has a great Thanksgiving as well. Thanks again.
Thank you, Chris.
Bye-bye.